Welcome to another BSPARI element brief training. Today's training is on non-operant conditions that influence behavior, presented by DBHDS Behavior Network Supports. The purpose of this training is to support behaviorists providing therapeutic behavioral consultation through the waiver system and their efforts to navigate the DBHDS DMAS Practice Guidelines for behavior support plans and the accompanying Behavior Support Plan Adherence Review Instrument, or BSPARI for short. The participants of this training will define non-operant conditions that influence behavior, become familiar with areas addressing this topic in the practice guidelines for behavior support plans and in the BSPARI elements. They will identify examples and non-examples of plans meeting relevant BSPARI elements, and they will access research articles and other resources on non-operant conditions that may influence behavior. Non-operant conditions that influence behavior refers to factors that affect behavior which are not directly related to the process of operant conditioning. Operant conditioning is the process by which behavior is selected, maintained, and brought under stimulus control as a function of its consequences. Whereas non-operant conditions influence behavior irrespective of an individual's learning history, and this can take various forms, such as the following. Genetic predisposition can cause increased likelihood of exhibiting certain behaviors and influence what may act as a reinforcer or punisher based on an individual's genetics. For instance, Fragile X syndrome is associated with increased aggressive behavior, gaze avoidance, and various repetitive behaviors. An individual with this genetic disorder is genetically predisposed to engage in these behaviors irrespective of their individual learning history. Underlying acute or chronic medical conditions may also influence a person's behavior and should be considered during functional behavior assessment. For example, gastroesophageal reflux disease, also known as GERD, is a painful condition involving stomach contents entering into the esophagus and may elicit expulsions surrounding meals. A behaviorist would certainly want to consider this medical condition when an individual has a history of GERD and is exhibiting these type of behaviors. Pharmacological influences on behavior should also be considered, as medications or drugs can have a significant effect on an individual's behavior. For example, a side effect of some antipsychotics, akathisia, may cause restlessness, involuntary body movements, and atypical facial movements like tongue thrusting. Psychiatric and neurological disorders can also have a significant impact on the individual's behavior. For instance, psychosis, which is characterized by withdrawing socially, a decline in self-care behaviors, as well as delusions and hallucinations that can influence erratic behaviors. None of this is to suggest that environmental events do not influence a person's behavior if they have one of these conditions. Instead, this suggests that clinicians should consider the entire spectrum of what can influence behavior beyond one's learning history and the current environment. Also, let's not forget about respondent conditioning. Basic and applied research has reviewed avoidance, anxiety, fear, and phobias from this lens as it relates to challenging behavior. See the article by Brewer et al. On the references page of this training for more information about the interactions between operant and respondent behavior. These few examples are not an exhaustive list of additional non-operant influences of behavior. Challenging behavior can often be a combination of many factors which must be considered during assessment. The FBA process is essential to effective behavior support planning, and a comprehensive FBA should aim to thoroughly identify all factors influencing the behaviors of interest. This includes both operant influences, such as the effects of punishers and reinforcers in the environment, as well as non-operant factors as the ones just mentioned that may impact an individual's behavior. The DBHDS DMAS Practice Guidelines for Behavior Support Plans outlines the required content areas and associated minimum elements for behavioral programming through the Therapeutic Consultation Waiver Service. Non-operant conditions that influence behavior are addressed in the Functional Behavior Assessment section of the Practice Guidelines, and they state, if there are any known non-operant conditions that influence behavior, include such information in the section referring to the FBA section of the Behavior Support Plan. To be in alignment with these guidelines, the behaviorist must directly address non-operant influences on behavior. DBHDS has created the Behavior Support Plan Adherence Review Instrument, or BSPARI for short, to capture the minimum BSP content areas and minimum elements of those BSP content areas as outlined in the practice guidelines. The scoring criteria for this element of the BSPARI is defined as includes information about genetic abnormalities, medical conditions, and/or psychiatric and neurological dysfunctions, specifically as contributors to challenging behavior. For example, Prader-Willi, polydipsia, and epilepsy. Additionally, respondents explicitly labeled as relating to challenging behavior are included, or non-operant conditions as noted as unknown, not applicable, or other similar indication is provided that indicates this information is not available or relevant to this person. The plan must meet these criteria to be considered in compliance with this element of the practice guidelines. Let's take a look at a few fictional examples and non-examples of BSPs meeting the element of considering non-operant conditions that influence behavior based on the definition provided in the BSPARI. These are examples of meeting those criteria. The individual's medical history of frequent acid reflux may be contributing to the target behavior occurring more frequently after meals. And the behaviors targeted for decrease occur more frequently when the medication regimen is not followed. And lastly, during the FBA, non-operant conditions were not identified as influencing the target behaviors. And now let's look at some non-examples. The problem behavior is more likely to occur when there is a full moon. This statement is certainly non-operant in nature, but it does not contribute to the understanding of the conditions influencing the target behavior. And the individual has a history of frequent acid reflux. This is helpful information to include, but it does not directly state how the known medical condition may be influencing the behaviors targeted in the plan. And lastly, this element is not addressed when the behaviorist fails to indicate that the FBA did not identify any non-operant conditions that influence the behaviors of interest, if that is the case. Here are some additional resources for providers on non-operant conditions that influence behavior. Thank you for taking the time to review this training. Please explore our website for additional resources and training opportunities, as well as information on the BSPARI and the DBHDS DMAS Practice Guidelines for Behavior Support Plans.